Bismillahirrahmanirrahim. As you all know, today we'll be discussing video urodynamics. So, last Thursday, we have discussed some the setup, the indications, and the profile, the transducers. And today we'll be further discussing the abnormalities or pathologies, the reducer overactivity, underactivity, leak point pressures, and electromyography and urethral pressure profilometry. So just briefly reviewing, urodynamic study is basically the dynamic study of urine storage and urine evacuation. So in normal, what happens is bladder is a distensible structure. When bladder filling occurs, the bladder should distend at low pressures. And when the times come, when the appropriate time comes, when the patient goes to the washroom or when he urges to urinate, he should go in washroom, and then only the bladder should contract and the urethral sphincter should relax and the urine evacuation should occur with complete evacuation of the urine. And the bladder should be compliant, and as well as urethral sphincter should be continent. So this is the normal physiology, what happens normally. So today we'll be continuing and Dr. Aliha will present the further things which we need to discuss.
Assalamu alaikum. So I'm going to continue my presentation, which was not completed in last session. So we have covered the basics of cystometry. Now we are going to know what are the measurements we are getting via cystometry. So first of all, that's the bladder compliance. We have two types of bladder compliance. Number one is bladder capacity, cystometric capacity, and maximum cystometric capacity. So the difference in both of them is this: in cystometric capacity, that's the bladder volume which is at the end of filling cystogram when permission to void is given to the patient. While in maximum cystometric capacity, this is the volume at which the patient feels that he can no longer delay the micturition and has a strong desire to void. So there is not much difference between both of them, but in cystometric capacity, it is one which ends at the time when we give permission to the patient to void. But maximum cystometric capacity is quite higher than this cystometric capacity. Second thing which we get via cystometry is bladder compliance. Third is detrusor stability and sensations. During cystometry, under the normal circumstances, the bladder should fill to a capacity of at least 500 ml before there is a strong desire to void.
This point is very important. Although the normal capacity is 500 ml, but whenever you order a UDS, you pre-op, like last week we have discussed, we need to have FVC or the bladder diary, frequency volume chart of the patient. And from that FVC or bladder diary, you will have the idea how much patient is urine voiding. If he is voiding 150 ml or 200 ml, then you cannot expect to the patient can hold 500 ml or 450 ml. So while performing UDS beforehand, you must have FVC or bladder diary of the patient, and from that FVC or bladder diary, you can understand if he's going to hold 150 ml urine or going to hold 500 ml. So every patient 500 ml is not there. You need to have FVC or bladder diary before UDS.
Speed of the filler, 10 ml per minute or 100 ml per minute. If it's a neuropathic bladder small capacity, then
we will go
it's 10 ml, and if it's large capacity, then you can increase the flow. Otherwise, 30 to 50 ml per minute maximum.
So the bladder compliance is the second component which we get after cystometry. It's the relationship between change in bladder volume and change in detrusor pressure, and is measured in ml per centimeter of water. There is a formula for it. That's change in pressure, change in volume, and change in pdet. The ICS recommends two standard points. Number one is the pdet at start of bladder filling. Usually it should be 0. And the pdet at cystometric capacity or before the start of any detrusor contraction that result in a significant leakage. So mean compliance in a healthy subject ranges from 46 to 124 ml per centimeter of water, but it is not applied to all patients, as we discussed that patients with multiple conditions like neuropathic bladder or small capacity bladder. So it is not for those patients. So here are the points. In non-urogenic bladders, normal compliance is more than 40 ml per centimeter of water, while those with low compliance, they have less than 30 ml per centimeter of water. In urogenic bladders, normal compliance should be considered to more than 30 ml per centimeter of water, and low compliance will be considered when it is less than 10 ml per centimeter of water. Impaired compliance could be due to spinal cord injury or spinal cord lesions like spina bifida. Increased outlet resistance like detrusor external sphincter dyssynergia. It could be due to long-term bladder outlet obstruction due to BPH, or due to any structural changes caused by radiation cystitis or tuberculosis like simple bladder. Number third point which we get with cystometry is sensations. As we some people should know that in last class we discussed that during the filling we measure the first sensation when patient during filling first sensation when patient felt, and the first desire to void and strong desire to void. So the first sensation of bladder filling is volume at which patient become first aware of bladder filling. And first desire to void is the feeling during filling systometry that would lead to patient to pass urine at the next convenient moment. While strong desire to void is the one in which patient is persistent desire to void without fear of leakage.
So when performing cystometry, you should be asking patient about these things. And when patient tells, you need to put a cursor or a mark in that tracing. What is the first sensation of bladder filling? What is the first desire to void? So this thing you should mark on that your graph, and you should ask patient.
So this is the normal filling and storage. Normally, diffuser pressure should remain near zero during the entire filling cycle until voluntary voiding is initiated. That means baseline pressure stays constant and low, and there are no involuntary contractions. So this line is showing the filling phase, and we are here see the pressures, and here is the volume. So we can see that there is no involuntary contraction, and the pressure is low and near zero. And this is the point where voiding starts, and at that time pressure starts and patient void. This chart this basically it is a summary of the storage and voiding phase. During storage phase, what are the normal function of diffuser and what is the normal function or normal activity of urethra? So in normal condition in storage phase, diffuser should be underactive. That means it should be relaxed and allow the filling. While urethra, it should be in contracted phase to maintain the continence. But what if storage phase is not working properly? So that means there are two things: diffuser abnormality or urethral abnormality. So diffuser abnormality is when diffuser is overactive or it is associated with any symptoms of urgency or incontinence. And if it is due to urethral abnormality, incompetent urethra, so it was associated with again stress incontinence. For voiding phase, there are again normal and abnormal things. If voiding is normal, then diffuser should be active. That means it should contract normally to allow the expulsion of urine. While urethra, it should be in underactive phase. That means it should not contract. It should be relaxed so to allow the flow of urine outside of the bladder. But if there is any abnormality with voiding phase, it again could be due to diffuser muscle. Like if diffuser muscle is underactive, it could not be able to contract properly, so it would lead to the stasis and unable to propel the urine outside. But if it is due to urethral abnormality, so in this case it is obstructive. If urethra is not opening properly, not relaxed properly, so it will lead to the obstruction and again lead to the stasis and patient unable to void or evacuate.
Whenever the patient is presenting to you with lower urinary tract dysfunction, and you are performing the urodynamic study or you are evaluating the patient, always consider the problem could lie either in the bladder or it could lie either in the outlet. So, and then you perform the study, and when you identify it, where is the problem? Either it is in the bladder or it is in the outlet, and then only you can treat. If the problem is in the bladder, it's a small capacity bladder, then you may need anticholinergic or augmentation. And if the problem is in the outlet, maybe due to the stricture urethra, maybe due to enlarged prostate, then the treatment will be different. So you need to understand where the problem lies, and this study will help you to identify where the problem is.
UDS observations recommended by ICS. Number one is the physiological filling. It is the filling rate less than the predicted maximum. The predicted maximum is the body weight in kg divided by 4 and expresses ml per minute. Typically, it ranges from 20 to 30 ml per minute, as Dr. Murli said. Non-physiological filling rate are the filling rate greater than the predicted maximum, which commonly used. Reduced bladder sensations. These are the diminished sensation throughout the bladder filling. Absent bladder sensation are the no bladder sensation or non-specific bladder sensation. The individual is aware of bladder filling, but because of other sensations such as abdominal fullness. Diffuser overactivity. It is an involuntary diffuser contraction IDC during the filling phase, spontaneous or provoked. It could be phasic or it could be terminal. Diffuser overactivity incontinence. It is the incontinence related to involuntary diffuser contraction. It can be due to neurogenic or idiopathic causes. Provocative maneuvers. These are the maneuvers or techniques which we use during urodynamic order to provoke the diffuser overactivity.
So these ICS or urodynamic observation, you must be very specific about it. There is a chart in the Campbell, and from exam point of view as well, and also in the clinical point of view, you should very specifically use these terminology for the examiner and as well when you're performing UDS or interpreting it. So you need to very clearly interpret that urodynamic observation, and definition are very peculiar.
Between overactive bladder and day to the overactivity. Overactive bladder and day to the overactivity. Is there any difference between both of them? Overactive bladder, patient will tell you that he has urgency and frequency, nocturia, maybe incontinence or not. So these are the symptoms stated by the patient. Day to the overactivity is the urodynamic finding of these same symptoms, but proved by urodynamic. So this is different, overactive bladder and day to the overactive.
That means that is subjective and objective. So abnormalities of bladder filling, detuser overactivity, it is the urodynamic observation characterized by involuntary detuser contraction of any amplitude during the filling phase, which may be spontaneous or provoked. It can be provoked by rapid filling, use of cold or acidic filling medium. Stress-induced detuser overactivity. Sometimes detuser overactivity can be triggered by a rise in abdominal pressure. Thus, the symptoms may appear to be stress incontinence, but the condition causing symptom is actually an involuntary contraction, not a sphincter weakness. In a patient with stress-induced detuser overactivity (SIDO), it is important to note if there is also urodynamic stress urinary incontinence and/or detuser activity independent of stress-induced detuser overactivity. This is the chart taken from Campbell, which showing the detuser overactivity. Here we can see this is the basically P vesical pressure. This is a graph showing abdominal pressure, and below one is the detuser pressure graph. So we can appreciate the graph positive deflection in the vesicle and detuser graph. So this is basically the involuntary detuser contractions which are consistent with the vesicle and detuser in the detuser graph. So these are the 2 points where detuser overactivity is noted. As I already told you that there are a few types of detuser overactivity. Number one is the phasic detuser overactivity. It is characterized by a characteristic waveform that may or may not lead to urinary incontinence, which is shown here in the filling phase. These are the contractions which cannot lead to the incontinence. While terminal detuser overactivity is a single involuntary contraction of the detuser muscle which occurs at systometric capacity that cannot be suppressed, result in incontinence with bladder emptying. Here is a terminal DO. This lead to the incontinence, and here it shows in the flow chart also. Post-micturition detuser overactivity, it occurs after voiding, usually in the presence of detuser and/or urethral instability. Now, for voiding phase, it is the evaluation of voiding phase provide an assessment of both detuser contractility and bladder outlet resistance. The two parameters that are critical for normal bladder emptying. In simple terms, abnormalities of bladder emptying are caused by overactivity of bladder outlet, underactivity of detuser, or combination of both. According to the ICS, normal detuser function is characterized by a voluntarily initiated continuous contraction that leads to complete bladder emptying within a normal time span and in the absence of any obstruction. Detuser underactivity is defined as when there is a contraction of reduced strength and/or duration, resulting in prolonged bladder emptying and/or failure to achieve bladder completely within a normal time span. Finally, an acontractile detuser is when there is no demonstrable contraction during the UDS, is known as acontractile detuser. So UFM, I hope all of you know that what is the UFM. It is the simple non-invasive diagnostic procedure which calculates the rate of urine expulsion as the function of time. It is performed by having a person urinate into a funnel connected to an electronic measuring device. The measuring device calculates the mass of urine produced during the interval from initiation until completion of void. This information is converted into an XY plot with flow rate ml per second. It is commonly performed to determine if there is an obstruction to normal urine flow. Some of the medical conditions that can alter the normal flow of urine are BPH, urine blockage, CA prostate or bladder tumor, urinary incontinence, and frequent UTIs. This is the normal flow curve, which we know as the bell-shaped curve. This bell-shaped curve basically is in which a Qmax is achieved within initial 1/3 of the total voiding time. The ICS recommends that 1 ml should equal to 1 second on x-axis and 1 ml should equal to 10 ml on y-axis. So this graph, this is a time to maximum flow, which is achieved in 1/3 of the 1/3 time, and this is the flow rate. These are some abnormalities of this UFM. This is a normal graph. This is the obstructive picture, which is in which we can appreciate that pressure is not that much and urine volume is not is empty till 40 ml, 40 seconds, 50 seconds, slowly and gradually. This third graph is the specific interrupted pattern, interrupted or straining pattern, which we see normally in BPH patient, large prostate patient. Now move towards the pressure flow study. There is a simultaneous measurement of bladder pressure and flow rate throughout the micturition cycle. The best method of quantitatively analyzing the voiding function. Access to bladder via transurethral or SPC 8FR or less. Intra-abdominal pressure measurement by balloon catheter into the rectum or vagina or any stoma if patient is having any CA of rectum APR was done previously. Men should void in a standing position while women seated on commode. Indication for pressure flow studies. Number one is low or normal diffusal pressure and high or normal flow rate, normal or unobstructed voiding. Number second indication is high diffusal pressure and low flow rate. Number third indication is low diffusal pressure with low flow rate, that is diffuser underactivity. So this is a typical working station for this pressure flow study. Number A is indicating the transducers, which we last time discussed. The number B, it is the pump of bladder filling. The third is the screen, and D is UFM, the funnel shape uroflowmetry area. So this graph is showing the schematic representation of pressure flow studies. Here is the pre-micturatory pressure. These are the intravesical pressure before micturation, and these are the diffusal pressure before micturation. So if you're considering it is the normal and filling phase, so these are the baselines, and these are near zero. And when permission to void given at this point, the pressure start to rise, diffusal pressure will start to rise again. And along with this, intravesical and intra-abdominal pressure, these are also increased. And this graph and this graph are showing that voiding is occur, and this is the flow graph which showing the flow of urine. So there is no obstruction in normal voiding.
So these pressure flow study is very important in context to bladder outlet obstruction. We see so many patients in our OPD, and we see BO written or BO written. So what is bladder outflow obstruction? Can anyone define this? That can be a cause of it. What is the definition? Bladder outlet obstruction. So it is the high pressure with poor flow rate. So whenever we are ordering UDS from prostate OPD or from any OPD, and in a patient of enlarged prostate, so we are performing urodynamic study, and in that study you can see on the voiding phase the detusal contraction is there, but the flow rate is poor. It means the detuser has the capacity to empty urine, and the detuser had performing good contraction. Then you can, if you perform surgery on that patient, then patient post-op will void very effectively. But if on voiding function the detuser is underactive or atonic, and as a result of that the UFM is poor, so if you perform surgery or TRP on that patient, after TRP he will not be able to void. So whenever you are investigating the UDS on large prostate patient, whenever you are reviewing the pressure flow studies, always see the detuser pressure and as well as flow rate. If the detuser contraction is strong and then it's poor flow rate, then surgery will benefit him. But if the detuser contraction is very less, and also as a result of that the pressure is the flow is very poor, then surgery will not benefit this patient.
So moving forward towards the bladder outlet obstruction index, this is the Abrams graph number, also known as the bladder outlet obstruction index, BOI. There's a formula for it, that is P dat at Qmax minus 2 into Qmax. This calculation will lead to a number which we measure at this graph: unobstructed, equivocal, and obstructed. If the answer is 40 or more than 40, that means it is an obstructed pattern. If it is less than 20 or 20, it is in unobstructed way, in an unobstructed graph. And if it is between the 20 to 40, this is the equivocal graph. Next is bladder contract.
Qmax minus 2 Qmax, इसको थोड़ा define करके बता दो, इसका मकसद क्या है? P dat Qmax minus 2 Qmax, पीछे थोड़ा, हाँ ये, तो ये इसका मकसद क्या है, क्या कहना चाह रहे हैं?
सर हमारे पास बेसिकली जो प्रेशर फ्लो स्टडी में किसी तरह का ग्राफ होता है जिसको हम यूजुअली इग्नोर कर देते हैं, पर दिस इज द वन जो ये ब्लैडर आउटलेट ऑब्स्ट्रक्शन इंडेक्स का ग्राफ है। उसमें हम पी रेटेड क्यू मैक्स की जो वैल्यू वहाँ पर लिखी होती है उसको लेते हैं एंड वी टेक द क्यू मैक्स। हम क्यू मैक्स उसको मल्टीप्लाई करके वट एवर द रिजल्ट वी गेट हम पी रेटेड क्यू मैक्स से माइनस कर देते हैं। सो जो रिजल्ट उसमें आता है उसको हम इस ग्राफ पे प्लॉट करते हैं। इफ इट इज मोर देन 40 तो वो ऑब्वियसली ऑब्स्ट्रक्टेड पैटर्न में आएगा। अगर ये
हाँ, नहीं,
लेस
वो
देन
तो सही है।
20।
मैं ये कहना चाह रहा हूँ कि जैसे पी डेट क्यू मैक्स है ना,
जी सर।
तो मैक्सिमम प्रेशर डेट टू द
Maximum
प्रेशर जहाँ पे पेशेंट ने अवॉइड किया,
जी सर।
और वो क्यू मैक्स अगर 7 है फॉर एग्जाम्पल, और डेट टू द प्रेशर 80 है, तो 80 से -2 क्यू मैक्स का मकसद है 14 माइनस करेंगे, ये
जी सर।
ठीक है ना?
जी सर।
तो इसको डिफाइन अगर हम करें कि पी डेट क्यू मैक्स माइनस क्यू मैक्स 2 क्यू मैक्स का मकसद है जो क्यू मैक्स आया मे बी
Sir,
6
twice
और
लेंगे।
7 और 8, वो 2 दफा जोड़े 14 हो जाएगा, और जिस मैक्सिमम डेट टू द प्रेशर पे वो ग्राफ बना
जी सर।
तो उसी में से माइनस करेंगे। तो
सर मेरे पास की पिक्चर थी पर बस
हाँ।
आई नहीं है। Bladder contractility index BCI. This is slope of Shepherd's line, also known as Shepherd's described the formula for BCI. This formula is P rated Qmax again plus 5 into Qmax. If it is more than 150, that means that there is a strong contraction, a strong contractility. If it is 100 to 150, that means normal contractility. And if it is less than 100 or equal to 100, that is weakened contractility of bladder muscle. Video cystometry or video UDS. This is the simultaneous measurement of UDS parameter and imaging of the lower urinary tract. It provides the most precise evaluation of voiding function and dysfunction and is particularly useful when specifically anatomical structure and functions are important. Video UDS may also assist in identifying structural abnormalities such as prolapse associated with stress urinary incontinence, vesicovaginal fistula, urethral diverticula, or upper tract VUR. In context of male patient, it can be useful in demonstrating attenuation of prostatic urethra in association with prostatic outlet obstruction or confirming the diagnosis of bladder neck obstruction. This is the picture showing video UDS. The difference is this: in this we have the fluoroscopy guided UDS. Now moving towards the leak point pressures. There are two distinct type of leak point pressure can be measured in incontinent patients. Number one is abdominal leak point pressure. Number two is detrusor leak point pressure. Abdominal leak point pressure is defined as the intravesical pressure at which urine leak occurs as a result of increased abdominal pressure in the absence of detrusor contraction. It is a measure of sphincter strength or the ability of a sphincter to resist the changes in abdominal pressure. There is no normal abdominal leak point pressure as patient without stress incontinence will not leak at any physiological abdominal pressure. And abdominal leak point pressure can only be demonstrated to patient with stress urinary incontinence. The lower the abdominal leak point pressure, the weaker or less resistant the sphincter is. Abdominal leak point pressure, if it is less than 60 centimeter of water, that is significant intrinsic sphincter deficiency. If it is between 60 to 90 centimeter of water, that is equivocal, or it means that there is a component sphincter. If it is more than 90 centimeter of water, there is little or no intrinsic sphincter deficiency.
So abdominal leak point pressure, if the patient does not exhibit a leak from periurethral catheter, then you remove the periurethral catheter and then assess the leak from the transvaginal or rectal catheter.
ये जो LPP है ना, तो मेजर करना थोड़ा सा, कल मैं देख रहा था किताब में कि इसको मेजर करना इतना सिंपल है, आसान नहीं है, और कह रहे हैं कि अगर लो एब्डोमिनल प्रेशर पे पेशेंट लीक कर रही है तो देन ये इंटरनल स्फिंक्टर डिफिशिएंसी है, अगर हाई पे कर रही है तो हाइपर मोबिलिटी, थ्योरेटिकल होती बात उसमें थी, मगर वो उनका मकसद ये था कि ये जो हमने रीडिंग्स दी ना, थोड़ा डिफिकल्ट है एब्डोमिनल लीक पॉइंट प्रेशर देखना, और वो ये रिकमेंड कर रहे हैं कि वैसे भी यू कैन सी ऑन कफिंग, वो ज्यादा बेहतर है देन यूरोडायनामिक्स, एंड देन someone is looking there and patient is in distress.
Yes, sir.
So book is advocating that other measures or other investigations should be tried for that, but if it's not confirmed, then urodynamics and this LPP. But it's difficult to give readings.
Yes, sir.
Second is the detrusor leak point pressure, DLPP. It is defined as the lowest detrusor pressure at which urine leak occur in the absence of either a detrusor contraction or increased abdominal pressure. It is a measure of PDAT in a patient with decreased or poor bladder compliance. It measures the bladder response to increased outlet resistance. The higher the resistance, the higher the DLPP, which potentially dangerous to the upper tract, which obviously lead to the VUR. Detrusor leak point pressure of more than 40 centimeter of water is associated with upper tract damage, VUR, or hydronephrosis in 85% of myelodysplastic kidneys. However, this cutoff of 40 centimeter of water is not absolute.
So this detrusor leak point pressure is in context of bladder compliance. If the bladder, it is a disease bladder. If the urethral incontinence, if the urethral mechanism is intact, it means the pressure will rise, the detrusor pressure will rise, and it will be transmitted to upper tract, and it eventually will lead to renal failure. If the outlet resistance is weak, then the leak will occur periurethral, and the pressure will not rise significantly. So if the outlet resistance is increased, then this detrusor leak point pressure is very important, because the pressure will rise significantly in the detrusor and it will be transmitted to the upper tract. So if there is outlet resistance is weak, then sort of pop-off mechanism occur and the urethral leak occur and the pressure will not rise and the upper tract will not be damaged. So this is very important in it happens in the disease bladder like tuberculosis cystitis or post-radiation, or in upper motor neuron or lower motor neuron lesion. So this detrusor leak point pressure is very important.
We also see in clinics that patients who leak with the rise of detrusor pressure, or they have problem of incontinence, their upper tract are saved.
Yes.
I sometimes say that because of this incontinence, your kidneys are saved.
Yes.
But that is a problem for patient as well.
Yes.
Incontinence all the time, or maybe when they feel urgency and they leak.
Yes.
So, but upper tract is saved.
Yes.
Because of that.
Double-edged sword. If leak upper tract is safe, it doesn't leak, the upper tract will get damaged.
अगर इसको इस अंदाज से देखें ना कि for instance, if we want to apply some kind of a therapeutic solution to it, then there are patients who not here but elsewhere they need artificial sphincter. Now, the value of abdominal leak point pressure specifically is when you provide artificial sphincter, you do measure abdominal leak point pressure before the procedure, and you try to gauge the contractility of the artificial sphincter after you have put in. तो प्री ऑप और पोस्ट ऑप, और कितना वो आर्टिफिशियल स्फिंक्टर को आप कॉन्ट्रैक्टिलिटी प्रोवाइड करेंगे, दैट डिपेंड्स अपॉन द ग्रेजुएशन ऑफ दैट मटेरियल जो कि आपने उसको प्लेस किया है एंटी एब्डोमिनल वॉल में या स्क्रॉटम के अंदर, वो जो एक बॉल शेप्ड स्ट्रक्चर होता है, हमेशा उसका प्रेशर सेम नहीं रहता. उस प्रेशर को आप इंक्रीज या डिक्रीज कर सकते हैं अकॉर्डिंग टू योर ओन रिक्वायरमेंट. सो हाउ यू इंक्रीज और हाउ यू डिक्रीज, इट डजंट डिपेंड अपॉन एनी इंप्रेशन. मतलब मेरा इंप्रेशन है कि इस पेशेंट को लीक हो रहा है, आप उससे कहते हैं खांसी करो और लीक हो, आप उसका प्रेशर बढ़ाए चले जाएं, वो तो सारा का सारा इरोड करके रख देगा पूरा ब्लैडर नेक को. आपको असल जो चीज गाइड करती है ना, वो प्रेशर्स गाइड करते हैं. सो यू ऑलवेज इंक्रीज द कॉन्ट्रैक्टिलिटी ग्रेजुअली and decrease the contractility gradually, measuring abdominal leak point pressure. So it has got its own value and implication where detrusor function doesn't come into play. वजह उसकी है कि detrusor failure नहीं है. When the sphincter is gone, for instance, अगर sphincter नहीं है, या ये कि आप यूं कह लें कि उसको sacral agenesis है, तो bladder is normal, storage capacity is normal, लेकिन उसकी जो continence mechanism है, it is lost. So you are mainly concerned towards the आप सिर्फ वहीं पे अपने आप को जो है ना फोकस करते हैं, and then you provide some solution. तो इसकी ना फाइन ट्यूनिंग और फाइन इसकी जो बैलेंस है वो वहाँ पे क्रिएट होता है. So there is a value of it.
So next is electromyography. It uses special sensors to measure the electrical activity of muscles and nerves in the and around the bladder and sphincter. The sensors are placed on the skin near the urethra and rectum and or on the urethral or rectal catheter. Muscle and nerve activity change. The pattern of nerve impulses show whether the message sent to the bladder and sphincter are coordinated correctly. This measurement of striated sphincter muscle of perineum is done to evaluate possible abnormalities of pelvic muscle function. EMG activity measured during both filling and emptying. It performed in needle electrode or near surface electrodes, the muscle to be evaluated. Signals may be recorded by surface electrode or by hooked wire electrodes introduced into the periurethral muscles. Before filling, patient has to demonstrate violational control of sphincter, intact pyramidal tract, cavernous reflex is tested, intact sacral arc. EMG activity gradually increases during the filling cystometry and then ceases and remains so for the time of voiding. Once bladder is empty, sphincter EMG activity resumes. The failure of a sphincter to relax during micturition is abnormal. In patients with neurological disease, this is called detrusor sphincter dyssynergia. In the absence of neurological disease, it is called pelvic floor hyperactivity or dysfunctional voiding. Kinesiological studies do not diagnose neuropathy but may characterize the effects of it. Important role of EMG in identification of abnormal sphincter activity in patients with neurogenic bladder dysfunction and in those with voiding dysfunction of behavioral origin.
So this indicate during normal voiding, not only the bladder or the urethra or the continent mechanism play a role, but pelvic muscle also play a role in normal voiding, and it can cause a dysfunctional voiding. So this electromyography can help in very much to identify the abnormality and to treat. And sir, we are planning to incorporate electromyography in our UDS study very soon, and we are planning to incorporate it.
Maybe in a month or 2 months time, we'll have a symposium here in SIUT about kinesiology.
Yes.
So specifically, we are working on it. So I have proposed the physiotherapy department to come forward and let's start something which hasn't been done for the past maybe 30 years or so. So nobody can fall from the sky. कोई फरिश्ता तो आके हमें नहीं सिखाएगा ना, तो यहाँ पे हम नहीं सीखना है, तो इसको आगे बढ़ के जो है ना सीखने की कोशिश करते हैं. तो they have welcomed the idea and they are now gathering the people who can talk about it and they can train us.
Yes, sir.
Maybe we can induct 1 or 2 people और देखते हैं इस तरफ चलते हैं, because this is very important. If you have established a clinic, then my assumption is it should have the complete spectrum of everything. At least wish list तो होनी चाहिए ना.
Yes, sir.
अब उसको आप महदूद ना करें, उस wish list को आप बढ़ाते चले जाएं, because science is never something which has got a full stop. It is always comma and semicolons. That's it.
Yes.
Last but not the least is the urethral pressure profilometry. Urethral pressure is defined as the fluid pressure needed to just open a closed urethra. It's a small catheter with lateral apertures is used through which fluid is continuously infused. Simultaneous urethral and bladder pressure is measured as the catheter is slowly withdrawn out of urethra. This picture basically demonstrating the pressures measured at the different points. Number 1 at the bladder, neck or prostatic urethra, and till we withdrawn it, we measure the pressure at different levels. Urethral pressure profilometry definitions by ICS. A normal urethral closure mechanism, this maintains a positive urethral pressure enduring bladder filling even in the presence of increased abdominal pressure. Incompetent urethral closure mechanism is defined as one allowing leakage of urine in the absence of detrusor contraction. Urodynamic stress incontinence is involuntary leakage of urine during increased abdominal pressure in the absence of any detrusor contraction. And leak point pressure we already discussed. Maximum urethral pressure is the highest pressure measured along the urethral pressure profilometry. The maximum urethral closure pressure is the maximum difference between the urethral pressure and the intravesical pressure. And functional profile length is the length of urethra along which urethral pressure exceeds intravesical pressure in women. So this is the graph showing maximum urethral length, total profile length, and maximum urethral closure pressure, which is from 20 to 120 centimeter of water. And this bladder pressure minus maximum urethral pressure minus bladder pressure is the maximum urethral pressure.
It's written in Campbell that its clinical relevance is controversial regarding this urethral pressure profilometry, and it is written in women functional length of 3 centimeter and maximum urethral closure pressure of 20 to 40 is normal. So why is this clinical relevance is controversial, and we will know very little about this because of difficulty in performing or something else?
Yeah, difficulty in performing, and I think clinically it's not reliable. That's why people do not advocate for this, and maybe we should see in our setup as well and do on our patients and then see.
Yes.
But we conducted 2-3 workshops with the Dr. Solomon. He was also not keen for urethral pressure profile for patients.
Okay.
So, but we should see in our setup as well, what is
Sure.
the importance of this? It's written in literature. There must be some importance somewhere in the management of patients.
Yes, sir.
So, but I don't know about it. But practically, we are not seeing it and
Yes, sir.
we are not doing it. So, this is that.
Sir.
Sure, I've seen doing profilimetry somewhere else, not in Pakistan. But when it was done, there are two ways of doing it, and both of the ways have got the same kind of practical steps. The first step is to place the transducer, that is the catheter, within the bladder, and then you withdraw the catheter at your own will. That means you can do it by your own hands, by the pull of your own fingers, and that recede of or withdrawal of the catheter actually changes something on the screen, and that is the change in the pressure flow, right? Now, there are again two ways of measuring it. One is in static position. The other one, when you ask the patient to start micturating while you are actually withdrawing the catheter out. Now, your speed of withdrawal may be different from my hand, my speed of withdrawal. So it differs, right? And it differs in having those flickers of pressure changes on the graph. So what they proposed was another thing, and that is a robotic arm. It's not a robotic arm, but it is something which is like a kind of a pulley over which this transducer is woven. So the pulley moves out, and when it moves out, it recedes the catheter out, and then there's a jam. So what you can do is you can change the speed of pull of the pulley. So you can restrict it to maybe 5 centimeter per second, maybe 2.5 centimeter per second. So in that way, those 3 centimeter length of urethra or 4 centimeter length of urethra can be divided into segments of 2.5. So अगर आप 4 कह रहे हैं तो आप 2 segment तो कम से कम आप देख सकते हैं ना?
Yes, sir.
And then you can put markers after every 2 seconds, after every 2 centimeters, एक marker आप लगा के देखें उसमें pressure change कितना आता है. So the people who are doing it, they are doing it with a sort of commitment, and they are producing their own results. There are centers, for instance, the center in Bristol, where this gentleman, Abrams Griffith, he is a very senior person, might be retired now. So his center was Urospinal Center, who actually excels in all these things. So he has got all these equipments, and they are doing it properly. So maybe we can learn these kind of techniques from them, and then it will be better for us to understand the things
Yes, sir.
properly.
Yes, sir. Sure, sir. Sir.
बिल्कुल सही है.
Thank you.
और आपकी जो अंडरस्टैंडिंग है ना, जैसे अभी भी हम देखते हैं कि वीडियो यूरोडायनेमिक्स जो है वो कोई और कर रहा होता है, हम बाद में पिक्चर्स देख रहे होते हैं. So all these investigations are actually done with video urodynamics. They are not done without video.
Yes, sir.
इसलिए कि वीडियो पे आपको कंट्रास्ट मटेरियल नजर आता है, आपको नेक की क्लोजर ओपनिंग नजर आ रही होती है, वहीं पे आप मार्कर भी लगाते हैं, और दैट मार्कर इज एक्चुअली कंफर्मिंग, जैसे कि तंजील कह रहे थे, or whether this is a closing pressure or whether this is an opening pressure. So maybe the marker has been put by somebody else who doesn't know where the closing pressure is and where the opening pressure is, anatomically where the sphincter is.
Yes, sir.
So you are in a better position as a clinician, as a urologist who knows the anatomy, and you know where the sphincter is. So is it at the bladder neck, or is it at the verumontanum, close to verumontanum in a male? So this whole segment is very important, which is like a prostatic urethra in males. The rest is story.
One thing in urodynamics is important. Cough. You should always ask patient to cough for two purposes. One is that this reassures you that lines are inside and proper place. And second, sometimes you generate the induced responses, especially in your incontinence, stress incontinence. So cough should be asked to patient for many times, and maybe multiple coughs. So sometimes you miss small leaks. If you will not do multiple coughs at a time, cough is important. Cough reflex is important. To ask patient that cough after maybe 5 minutes, after 10 minutes. This will help you that to confirm that lines are inside the bladder and rectum and they are working. So that is important.
It was previously mentioned that at every 50 ml of infusion of fluid, we will ask the patient to cough.
Yes, this is important.
Yes.
Thank you.
Thank you.
Thanks.
Thank you.
It was
Thank you
good.
so much.
Nice presentation.